In this class, we will introduce paroxysmal nocturnal hemoglobinuria. Mutation of phosphatidylinositol-glycan class A leads to the abnormal synthesis of the glycophosphatidylinositol, usually called as GPI, anchor that attaches a subset of proteins to the cell surface. Lack of CD55 and CD59 on the red blood cell surface is mostly responsible for the clinical manifestations in PNH. CD55 and CD59 can inhibit complement C3 and C9 activation and protect normal red blood cells from hemolysis. In the steady state, PNH erythrocytes suffer from spontaneous complement activation, with consequent intravascular hemolysis through formation of the membrane attack complex. When extra complement is activated through the classical pathway, an exacerbation of hemolysis will result. PNH is an acquired clonal hematopoietic stem cell disorder. The defective synthesis of GPI affects all hematopoietic cells, including red blood cell, granulocytes, lymphocytes, and platelets. Only red blood cells are more sensitive to the lytic effect of complement. PNH can arise de novo or in the setting of an underlying bone marrow disorder, such as aplastic anemia, myelodysplastic syndrome, or primary myelofibrosis. Patients usually suffer from chronic intravascular hemolysis. Hemolysis syndromes depend on ratio of mutated clone to a healthy one in bone marrow and extent of GPI shortage. More acidification accumulated during sleeping precipitates hemolysis. Many patients present with unexplained hemolytic anemia and associated symptoms, including fatigue, jaundice, and red, pink, or black urine. Decreased bone marrow function in some individuals may further exacerbate anemia and cause pancytopenia. Another presentation of PNH is with thrombosis in an atypical location, such as Budd-Chiari syndrome, due to a hypercoagulable state induced by complement activation, free hemoglobin in the bloodstream, and possibly other precoagulant mechanisms. Intravascular hemolysis releases free hemoglobin into the circulation, and the resulting depletion of nitric oxide may cause symptoms of increased smooth muscle tone, including dysphagia, abdominal pain, or erectile dysfunction. Complete blood cell counting and biochemical tests are in accordance with non-antibody mediated intravascular hemolysis. Erythrocytes is usually hyperplasia, but bone marrow may present hyperplasia at late stage of disease. Hem test has high specificity, and sucrose hemolysis test has high sensitivity. They may be helpful for the diagnosis, but now have been substituted by flow cytometry. Flow cytometry detecting CD55 or CD59 negative cells with fluorescence antibody is usually used, mostly with 10% as judging boundaries. Fluorescent aerolysin, usually called as FLAIR, is a reagent derived from the bacterial toxin aerolysin, which binds directly to the GPI anchor. Flow cytometry detects GPI with flare has the highest specificity and sensitivity. It can detect as little as 1% of GPI negative cells. If the patients have evidences of chronic intravascular hemolysis anemia and no family history, we should suspect paroxysmal nocturnal hemoglobinuria. If hem test is positive and CD55, CD59 or flare test is positive, we can make the diagnosis. Eculizumab is a recombinant humanized monoclonal antibody against C5, which can stop hemolysis but failed to eradicate PNH clone. Eculizumab is recommended for patients with significant disease manifestations attributing to hemolysis, including disabling fatigue, transfusion dependence, frequent pain, paroxysm, thrombosis, worsening renal insufficiency, or other end-organ complications. Glucocorticoid is effective for partial patients, can reduce the attacks or relieve hemolysis. Sodium bicarbonate can be used in acute hemolysis. Antioxidants such as vitamin E have cytoprotective effects for the cell membrane, but the effectiveness is uncertain. Allogenic hematopoietic stem cell transplantation is the only curable therapy. Loss of iron through the urine may be significant. Supplemental iron should be administered to patients who are iron deficient. Supplemental folic acid is also used, as with other chronic hemolytic anemias. Red blood cell and platelet transfusions should be administered if clinically indicated. Patients with symptoms of thrombosis should be evaluated promptly and treated with therapeutic anticoagulation. Okay, that's all. Thank you.